Hey guys, we're back. Now we are talking about seizures. So think to yourself for a second what seizures might look like. I don't know if you guys have ever seen a seizure before or not, but if you have, think about what that looked like. Think about how that patient presented. We've very minimally touched on some of these presentations before. I inappropriately, and I apologize, called it the funky chicken, but that's what people typically think about is people laying on the floor and arms and legs are moving uncontrollably. The patient is unresponsive, they're not tracking you, sometimes they're foaming at the mouth, sometimes their breathing can be inadequate, all these kinds of things. So by definition, we're talking about a sudden change in behavior due to electrical hypersynchronization of neuronal networks in the cerebral cortex. So uh, there are different classifications of seizures. You can have focal seizures. So sometimes patients will just be talking to you and just kind of zone out, and then they come back, and so that could be they have some impaired awareness with that. You can have generalized seizures, tonic-clonic. That's your everything's shaking. You can get into atonic where they can't move at all. Absent seizures, maybe that's what I was talking about there. Again, there's different. One that's not on there is that PNES, so psychogenic non-epileptic seizures. Again, add that to your list. Take a look at that. But what kind of things can be causing seizure? Epilepsy. So is there a genetic or a structural abnormality that's causing this? Sometimes drugs and toxins, alcohol withdrawal. Again, there's hypoglycemia, hypoxia, stroke, traumatic brain injury, eclampsia. So this is when seizure is actually the mark point where you switch from eclampsia to from preeclampsia to eclampsia in pregnancy. So my mom has high blood pressure or has protein in her urine, all those kinds of things. Things that we have to be worried about is when they start seizing. You know, pre-hospitally, what are we going to do for these patients? Well, we're going to try and support their respiratory status. We are going to try and prevent them from worsening injuries. Put padding underneath their head. At the primary care level, you are kind of stuck to just helping them ride it out as best they can. Like I said, try and not restrain their arms, but help them from, if their arms are shaking violently and uncontrollably, remove sharp objects. If there's tables in the way, get them out of the way so they're not going to be hitting off those kinds of things. But call for your friends. Advanced care, we carry midazolam, and so we can give that to these patients and try and help them stop seizing. But if you're into something like eclampsia, they'll actually go as far as to, again, I'm not the doctor on this, but usually the treatment for eclampsia is to deliver the baby early because mom is at a state where this could be fatal to mom. So hopefully you're within that window where baby's viable and they can deliver baby early to prevent further seizures. Febrile seizures, common in kids. Most people, I get phone calls all the time from friends. Hey, my kid's got a temperature of 39. Like, I'm worried they're going to seize. Should I bring them to the hospital? It's not how high the temperature is, it's how fast the temperature gets there. That's concerning. So, things like that, they're usually self-limiting, I believe. So, but you'll probably have to get used to having your friends call you about those kinds of things. I'm not saying don't call 911 because your kid's having a febrile seizure. Certainly want to get them looked at, but it's not the number of the temperature they get to, it's how fast they get there. So if that's, they woke up this morning, they felt totally fine, and 2 hours later they got a super rapid fever, that's concerning, and they may seize. So there it is there. What are we going to do? We're going to assess ABCs. Nothing changes there. Consider C-spine, especially if their head's got some involvement and they've been sitting there smacking it off the floor or something like that, or they had a fall when the seizure started. Support the head. Don't put anything in the mouth. Here would be a contraindication to an OPA, for example. Protect the limbs, but don't restrain them. Again, you're just kind of help steering them so they're not hitting them off certain things. You can't really collect too many vitals accurately. While these patients are seizing, you might be able to get some glucometry done, but otherwise, once they are postictal, they're done with the motor aspect of things. Now we can start assessing their vitals and getting their heart rate, respirate. Nothing really changes here. Head to toe exam, rule out trauma. Sometimes incontinence can be a key thing to note, because when you are truly unconscious, you lose control of all your muscle, including the smooth muscle Well, that'd be smooth. Anyway, the muscle control of your sphincters, and if you have urine in your bladder, that urine will tend to flow out, and that's what causes you to pee. So it's not like they are actively trying to pee themselves. They don't have any control of this. You're gonna want to ask bystanders what they saw, because they might have a different story than what the patient saw. The patient might not even remember it or anything like that. But try and ask questions. Did you see their eyes deviate? How long did the seizure last? What parts of the body were involved? Try and ask the patient, if you can, do they have a seizure disorder? Try and ask, do they have multiple seizures when they have a seizure, or is it just one and done? Because these patients are known to have a seizure, and then 5 minutes later another seizure, and like those kinds of things. That's important for us to know. So treating, we don't carry Dilaudid, but here's a couple different meds that can be given. So maybe we want to even start asking, have you been taking these meds properly? Have we changed meds recently? Did we just get on these meds? Those kinds of things. Again, not an all-inclusive list here, but certainly questions we want to ask. When was your last seizure? Do you have stacks of seizures? Do they just kind of one and done? Have you had rapid onset of illness recently? Neck stiffness, maybe you're talking about meningitis, all these kinds of things. So, talking about generalized seizures, this is your tonic-clonic, or also known as your grand mal seizures. So, they're not necessarily preceded by an aura, but they can be. These patients typically lose consciousness. They have a tonic phase, which is that the muscles contract. So this is when they kind of stiffen right up. You might see that hyperextension in the back. And then that clonic phase, that's the muscle spasms. These patients can be in trismus, so super hard to get anything in their mouth in the first place, but it can affect all the limbs. We can go into a postictal stage. So this is after the seizure. They can be incontinent of urine. They're often confused and disoriented. So a big part of this is just the communication piece, just trying to talk to these patients, let them know what's going on. Make sure they know they're in a safe space. Maybe they bit their tongue, so you might see some bleeding and stuff like that. But these phases can last quite a long time, and sometimes they recover fairly quick. I don't know enough about saying, this is why they recover quick and why not, and all these kinds of things. But just know that this might be a 2-minute thing, it might be a 20-minute thing. But they don't always come out of their postictal stage. And so we can get into status epilepticus, and this is life-threatening. So now you've had 2 or more seizures without fully regaining consciousness. Here we're talking generalized or full-body seizures. Sometimes they can be focal. Those focal ones can be a little bit harder to find. But why are these really problematic? Your metabolic demands increase 100-fold for the brain. So if you're not getting that blood supply that you need to support metabolism, we are killing brain cells. So we want to end these seizures as quick as we can. The longer a seizure lasts, the harder it is to terminate usually. And I believe the longer longer it lasts, the harder it is to terminate, and the more likely it is to have another repeat seizure. We get into metabolic acidosis because you just have so much lactic acid production because your muscles are working so hard. With that, every time your muscles are working hard, your temperature increases. Your muscles are contracting so hard that you may actually fracture the long bones, which are your strongest bones in your body, being your humerus, your femurs. You have such strong contractions, those things snap. Just yikes, that is concerning, right? You can have simple partial seizures. Sometimes these patients remain conscious. They might have motor or sensory symptoms with it. Check that example out. And so what's causing these simple partial seizures? Here's a list of them. Again, is that an all-inclusive list? Probably not. But start trying to think about these things so that you can try and rule out some of them or fix some of them. If it's a hypoxic insult, does this patient need some oxygen to help get them up? Is it meningitis? Should I be thinking that, oh wow, this is something that my spidey senses are going off, this is meningitis. I should be protecting myself with some more PPE that I wasn't really alert to at the initial onset of the call. Moving on, we might see complex partial seizures. Again, you might have that loss of consciousness, you might not. But I guess they can have auras with this as well. They can have confusion. These patients, I'll let you read about this because I'm just basically reading off the slides to you. Absent seizures, also called petit mal. So there's no real known cause. They're rare over the age of 20. They can have a loss of consciousness or loss of awareness for 10 to 30 seconds. Sometimes the eyes just start fluttering. And then other kinds of seizures that we walk into, or run into, I should say, are alcohol withdrawal syndromes. So when someone's an alcoholic, alcohol is a depressant, it's a downer. So your body starts to upregulate how many receptors it produces so that it can have normal activity going on. Well, when someone goes through alcohol withdrawal, if they don't gradually get off the bottle, if they go cold turkey, now all of a sudden you don't have that depressant that you're getting all the time. You have this upregulation of what receptors are expressed, and all of a sudden you just have overactivity because you have so much stimulation on these receptors, and that can get into that seizure-like pattern and cause seizures. So we're talking 2 or 3 days post-withdrawal. So start asking these patients, when did you get off the bottle? Did you do it rapidly, or did you do a gradual kind of weaning off? This is why patients go to detox centers. I mean, in a boiled down version, is that they can have a gradual weaning off of the bottle. They can be supervised in case they do seize. They can get some medications to try and help them. They can get some medications to try and help prevent seizures and all those kind of things. And then I'm sure there's, coaching on how to live a healthier lifestyle and such. So, maybe they get introduced to benzos, benzodiazepines. So that was when I talked earlier about midazolam. Midazolam is a benzo that we carry to help terminate these seizures. So again, we can reduce that cerebral metabolic demand and try and prevent further brain injury from happening. So what are we doing to manage these seizures? The PCP level, try and get some vitals. We've already gone over this. Try and get that blood sugar. Rule out trauma, assess for C-spine, protect the head as best as we can. Get your friends started. There is, actually I believe it's now in motion. Soon the PCP scope will be getting midazolam. So maybe that's going to be less need to call ACP, but at the same time, you might need more hands. You might need airway control. Who knows? So if you need advanced care or higher, start calling for them. Otherwise, if you're not able to terminate the seizure, hopefully it ends soon and you're not sitting there for too long. But I've been on scene for patients seizing for 20 minutes as a first response. So not always the best calls to be on, but you're there. So do what you can and support their vitals as best you can. All right, that's the end of that.